Hello, everyone. Thank you for joining our second session for UX and for sharing your lunch with us. We know that this time of 12 noon is one where a lot of people have other plans, but we are so glad that you've joined us for this session. My name is Ellen Makar. I am a registered nurse and I'm part of the HIMSS UX committee. And today we are going to be talking to you about demanding a delightful care team experience. During this presentation, our speakers describe the impact change, fatigue, and burnout have on patient safety. They will analyze the user experience, tactics used by organizations that have transparent, intuitive clinical workflows, and they will translate how care team-focused user experience tactics can be integrated into your organization's clinical workflow. We are excited to bring to you two healthcare thought leaders to share their insights about clinician experience. Santosh Mohan is a health IT industry analyst researching successful processes, management practices, and emerging innovations that enable the role of technology in health system transformation. Santosh is the chair of the HIMSS Innovation Committee. Rasu Shrestha
Everyone.
is the Chief Innovation Officer at UPMC. He also serves as Executive Vice President of UPMC Enterprises, pushing the needle in pursuit of a unique blend of healthcare intelligence, technology experience, and entrepreneurial drive to develop intuitive and commercially successful solutions that address complex healthcare challenges. He is also a member of the HIMSS Innovation Committee. Please join me in welcoming our speakers.
Thank you. So I'll get started here, and then I'll have my colleague Santosh give a couple of words as well. So I know this is a lunchtime presentation. What we bring to you is food for thought. I'll stop with my jokes. The title for our presentation is Demanding a Delightful Care Team Experience, right? So you all know that the delivery of healthcare is about the care team experience. It's not just one physician. So I'm a physician by background, a radiologist by background. So it's not just a radiologist working with an ED physician, working with the nurse practitioner and the rad technologist. It is really about the care team with the patient at the center. So patient-centered care rolls off our tongues so easily, right? You ask any physician that you know, hey, do you practice patient-centered care? And they'll say, of course we practice patient-centered care. The challenge, however, sometimes is technology, right? Technology oftentimes gets in the way of us collectively, not just the physicians and the nurses, but us collectively as a health IT community. Technology oftentimes becomes an impediment to better care. What we're doing collectively is we're trying to make technology an enabler of better care. So that's in essence what we'll talk more about. No real conflicts of interests. We'll go through our agenda fairly in a systemized way. We'll talk about physician burnout. We'll talk about user experience approaches and give to you food for thought in terms of specific nuggets of what user experience is all about. We'll visit some really interesting case studies, and Santosh has some wonderful case studies to share with you, and we'll wrap it up with a delightful discussion at the end. These slides are also available for you to download online, so feel free to go through these. The value suite is fairly self-explanatory, and it actually does bring out the essence of what we're going to be talking about throughout our discussion today. A lot of it really transcends on the satisfaction and the treatment, because once you get better satisfaction, usability, increased productivity, less change, exhaustion, etc., you tend to then propagate the rest of what appears here in the value suite steps. So Tony Crossgrove, the CEO at Cleveland Clinic, talks quite a bit about the move from volume to value. We do this at UPMC as well. Our CEO, Jeffrey Romov, talks vehemently about this move from volume to value, and also about change and transformation, right? The way that we're practicing healthcare has changed remarkably over time. Tony here says things have changed, right? So it's not just about practicing medicine the old ways, it's really about the care team. As I alluded to earlier. It's about taking perhaps advice from the computer with clinical decision support systems. You heard earlier the keynote this morning from Ginny Rometty of IBM about artificial intelligence and machine learning and cognitive computing, right? So there are lots of technological capabilities that are really changing the paradigm. But it's also the paradigm shift in the way that healthcare itself is being transformed, right? So at UPMC, which is where I'm from, we're a payer and a provider organization. This yin and yang of a payer-provider system really brings to fruition the notion of value-based healthcare. It's not just volume-based anymore. But what we're also dealing with the rest of the healthcare community is how we're struggling with technology. We have a stellar IT team at UPMC, right? Bar none. I mean, we have one of the best IT teams, I'd say, internationally. And we're so good at rolling solutions out and making sure that we're able to handhold physicians and nurses as we go through go-live events and through support issues and everything else. But the reality of healthcare, not just at UPMC, but really across the board, and this is reflected by this Gartner AMDIS survey that was done of US CMIOs in 2016, is that there is a lot of frustration. There is a lot of burnout happening in how clinicians are feeling as they're caring for their patients, right? So we'll delve a little deeper into this. Bob Wachter, Dr. Wachter, wrote a book called The Digital Doctor. So how many of you have read this book? Excellent. For those of you who've not read the book, highly recommended. He's also on Twitter at Bob_Wachter. And he said, I realized that my beloved profession was being turned upside down by technology. And, he's not just, this is not a, hey, the sky is falling sort of a comment. This is reflective of many physicians who are dealing with the struggles of technology today. I'm not here to, we're not here today to say, hey, technology is bad, or, clinical information systems or the vendors are bad. What we're saying is there is, we are where we are today. We've implemented these solutions, and that's a wonderful starting point for us to really think about what's next and what the approach might be, right? So patient-centered care, oftentimes, that's the description of patient-centered care, right? The patient is at the center of care, but we're so busy inputting notes into our electronic medical record system or looking up charts, but that is not what patient-centered care should really be about. Today, with all of the advent of electronic medical record systems and clinical information systems, what we've ended up with is 44% of the time in this particular study that was done, the physicians, actually this was in an emergency department, were spending their time entering notes into the electronic medical record system, like clicking up to 4,000 times during a 10-hour shift, right? So this is in the place of perhaps communicating, talking to the patient, talking to their loved ones, having eye contact, engaging in dialogue and communication about what's important for that patient and what they should be doing, right? We're entering notes into the EMR. We're interacting with the clinical information systems. So again, look, there is a need for us to interact with the electronic medical record systems, with the clinical information systems, for me to pull up the lab values, for me to look at the X-ray scans, for me to look at recommendations and clinical decision support. But that onto itself is not enough. So today there's a lot of burnout. And what you see here are there are three specific elements of what's going on. There's emotional exhaustion. There is cynicism, right? So 50% of physicians admit to at least one symptom of burnout. 50%. At UPMC, we have 3,800 physicians. That's a lot of physicians who are admitting to at least one symptom of burnout. Cynicism. 57% of clinicians say that they feel more attached to their computer than their patients on most days, right? So they're cynical about it as well. Ineffectiveness, right? So technology is great. We're arguably more accurate today, arguably more efficient today, more productive today, and we've tracked productivity and efficiency with the rollout of electronic medical systems. But at the same time, there are these adverse effects of the success that we've had in this phase one of going from analog to digital. You might have seen this survey this result that actually came out, this research study, excuse me, that came out, and it was published in 2016, end of 2016. This was actually published in the BMJ as well, the British Medical Journal. And it said that the deaths in the United States because of medical error actually ranks number 3, right after heart disease and cancer. And that's a really interesting way to look at the impact that something like user experience or the lack of design thinking, which we'll talk more about, has in the deployment of clinical information systems. What's also interesting is what I put on the side there, which is ineffective communication is associated with approximately 95% of malpractice suits. That's ridiculous, right? There was a piece that I'd written sometime recently called the illusion of communication. The illusion of communication that exists between care teams, between the patient and the physician, between IT and the clinicians, perhaps, right? So how do we better this? How do we leverage the very thing that we're talking about, technology, to turn it around and make sure that we have a better endpoint? So when you drill deeper into the specifics of usability and the role of IT, the first thing we got to do is really figure out what the priorities are, what the problems are, right? And from a user experience perspective, there are 5 problems from a clinical documentation perspective. You see that there are multiple clicks, right? So you talk a lot about, hey, how do you decrease the number of clicks? And we're doing everything that we can right now to decrease the number of clicks. I won't go through every one of these, but from a nursing perspective as well, workflow is critical. Workflow is so critical. It's not just about, like I said earlier, the radiologist that's reading that study and churning that report in as quickly of a report turnaround time as possible. It's also about the radiologist really becoming a physician consultant, right? That's the emerging role in value-based imaging, is for imagers, radiologists, pathologists, cardiologists, the other ologists, to really become physician consultants, where they can consult alongside the surgeon who's about to operate on that patient the next day, right? With the nurse, with the technologist, perhaps even with the patient, right? So how do we make sure that the handoffs happen properly, that interoperability happens the way that it's supposed to? How do we make sure that we're able to leverage technology as a tremendous asset to really push forward with the care that we need to be providing to our patients? So as some of you might know, both Santosh and I are actually fairly active on Twitter. Sometime last year, I sent out this tweet that's on the other side of the screen there with the ketchup bottles. And it's a simple analogy, very simple, right? And I said, look, we have so much to learn from this for healthcare. So how do we better leverage user experience and design thinking? Dr. Joyce Lee, who is a great design thinker, actually pulled out that tweet, and she wrote a really interesting blog post that was picked up by a number of, including Fast Company, I think, picked it up too. And she elaborated further on this notion of the sad state of product design and innovation in healthcare. So how do we go about doing this? One key thing that we leverage at UPMC and at UPMC Enterprises, which is really the innovation and entrepreneurial arm of UPMC, is this notion of human-centered design, right? How do we make sure that before the first line of code is written, before the first system is actually unboxed and implemented, that we actually have more of a human-centered design process to going about the task of writing code or creating software or implementing a solution. So what I've depicted here, inspired by IDEO, which is a think tank around design thinking, is there are multiple levels of functionality, right? There's non-functional, there's functional, which works really well oftentimes, but there's also the delight factor, right? How do we make sure that we're able to create solutions and implement solutions to delight our users, right? When was the last time that a clinician went in and said, hey, I'm having a go-live event tomorrow. I am so delightful. Not very often, right? So how do we create to that? So human-centered design is also about simplicity. I think healthcare today is riddled with complexity. It is so darn complex. Everything is complex. The ICD-9 to 10 movement that we just had. oh my goodness, we have so many more codes, right? The tasks that we're inundated with, the data that we need to decipher. We're more of a detective than we are clinicians, right? Think about that. So how do we simplify things? So from a human-centered design perspective, it really is about simplicity. It's looking at and cutting through the superfluous details to get to the user's core needs. What does the user really need? So let's break it down really quickly before I hand it over to Santosh. A human-centered design has a number of components. First and foremost is really the contextual inquiry. The context is king. It's really important for us to have context around the specific workflow. So whether it's for that radiologist that's reading the study of the patient who came in with a pneumothorax, or whether it's for that patient who came in because he's had wheezing for a while, right? What's the context of this? Or is this a patient who's coming back for the 10th time for a follow-up for a certain something that is recurring over and over again, right? So observing the user context and asking structured questions to better understand what they're doing and why they're doing it is really important. Then there's UX design, and I'll delve a little deeper into this in my next slide. But it's really about enhancing satisfaction by looking at usability and accessibility and efficiency. And user experience is really important. Usability testing is important as well, right? So this is oftentimes when you think about user experience, a lot of people say, oh yeah, we do usability testings, right? There are lots of questions. Earlier we were having a discussion about, hey, are you engaging patients in the design of the solutions that you're creating or in the deployment? Are you really talking to your end users? It could be a patient, it could be a technologist, it could be clinicians. And most people will tell you, yeah, we engage them. And when we do usability testings, when we've created the software already, we find out from them, we do surveys. But oftentimes that's a little too late, right? What we're talking about here in usability testing is you have to engage them through and through. It has to be an iterative process, and it has to start before the first line of code is written or before the software is even unboxed, as I mentioned earlier. And then how do you refine it, right? So after testing it, after designing it, how do you make sure that you're able to refine it further? Here's another look at a more astute level of design thinking, right? So if you look at design thinking, it's the notion of starting first and foremost with empathy, okay? I talk a lot about empathy on social media. Santosh and I participated in tweet chats where we talk about the role of empathy, or the lack thereof today. Not because we don't empathize with our patients, but because we don't have the time to empathize with our patients, right? So empathy is important not just in delivering excellent clinical care. Empathy is important in looking at how do you better design solutions that better patient care? How do you look at bottlenecks that you have in the deployment of solutions so that you're able to really get to the essence of the value that the solution is able to bring together in care teams across the board. So design thinking starts with empathy, but doesn't end with empathy. It continues on to defining the solutions, it continues on to ideation, and then prototyping and testing. And it's a virtuous cycle back and forth. So I'll tell you, at UPMC, we're embracing the notion of design thinking. I work primarily in a group at UPMC called UPMC Enterprises. And UPMC Enterprises is a group that really is tasked with looking at the pain points that exist in the delivery of care. And we work hand in hand with the rest of the payer-provider organization, that is UPMC, with clinicians, with our colleagues in IT, with our colleagues on the operational side, and we identify those specific pain points. Once we identify those pain points, we then huddle together and come up with solutions that we might be able to create, or partnerships that we might be able to inculcate in the industry. Because we're not the only ones that have these pain points, right? So how do we make sure that we're able to leverage the principles of design thinking is something that we've actually embedded into the very nature of how we do things at UPMC and UPMC Enterprises. So human-centered design and design thinking is a set of processes. When you come, if you ever come, and please, you're welcome to come visit us, at UPMC Enterprises, you'll see walls, the entire floor filled with whiteboards and lots of sticky notes. For some reason, design thinkers love sticky notes. And it's really about the agility, right? How do we make sure that we're able to, in a very fluid and dynamic way, engage in meaningful dialogue with the end users, with the clinicians, with the IT staff, with patients, and think through these processes and go through this process that I described. So before I hand it off to Santosh, I'm going to pull a video up, and it's about empathy. It talks a little bit about the difference between empathy and what a lot of people confuse empathy with, which is sympathy, right? You go into healthcare oftentimes in the most trying times of your lives. If you can think about it, right? I mean, you've got this patient, and she's gone through this journey that no one ever wants to be in, and she goes into this healthcare institution to get care, right? And perhaps you sympathize with the patient, and that's important. But what we really need to do is bring out empathy, right? How do we bring out empathy? So this video will, I think, quite clearly illustrate what empathy is all about and the difference between empathy and sympathy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had it, yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Isn't that a brilliant video? So I'm going to hand it over to my colleague, on cue, Santosh.
Thank you, Russ.
Absolutely. So while Santosh is bringing this up, get ready with your questions. So Ellen's going to moderate a Q&A session at the tail end of our presentation.
All right. Thank you, Rasu. Climb in the hole and never say at least. Wow. So how many times have we in IT taken this approach with our clinician partners? Perhaps we should count how many times we have not, no? Here you have these highly trained experts trying to care for patients, and they're feeling slowed down. They're feeling frustrated because of the multiple levels of disruption to their practice, and they're sharing the problem with you, and IT says, hey doc, at least you're able to log in. at least you are able to pull up the chart. At least you are able to print. We're telling them to look at the bright side, and we're comparing their problem with what we perceive as something bigger in another application area or department. The most awkward remark I've heard is this doctor sharing with the meaningful use analyst, how he's feeling really slowed down with all these data that he has to collect. And the analyst goes, "Hey doc, do you want to go back to paper?" No, we don't want to go back to paper, just as we don't want to go back to the days when we had horse-pulled buggies. But at the same time, we don't want to be stuck in traffic on the freeway, right? And when we are actually on the floor trying to troubleshoot an issue, how often do we stay in the emotion with the person instead of jumping straight into the problem-solving mode? Do any of these approaches help improve the experience of people using the tools that we provide? Do they improve the experience of doctors in helping them do their jobs better? No, absolutely not. And we'd know that if we placed ourselves in their shoes. We'd know that if we empathized. We'd know that if we climbed down that hole. And if we did that, my friends, would we design their experiences any better? Yes, I'd like to believe that we would. And this is why empathy-infused interviewing, which is a design thinking tool, which nicely illustrates how to actually apply what we've heard in the video, focuses on active listening. It focuses on exploring emotions and evoking stories without interjecting with data or diagnosis until you get to the right point. To deliver experiences that truly delight people, we must be sensitive to their thoughts, to their emotions, to their motivations. We need to observe and understand what their hopes are, what their fears are, what their goals are, and the context in which they're working. We need to see through the eyes of our peers what their struggles are and what their triumphs are, and then understand how we in our role can impact a change. And so much of this is implicitly understood than explicitly described. This is why it's so important to go round on our clinicians. Yes, IT rounding is about getting in front of our clinicians, talking with them when they have the time, and asking how they're doing. How else can we stay grounded in our users' experience with the tools and services that we provide? This is absolutely about figuring out how to be proactive than reactive. It's about meeting people's expressed and unexpressed needs. And while we are doing this, we must do it with empathy. I think just this would help improve the service aspect of design so much. Service design aspect of the experience so much. But if you want to take a step further, a great companion tool for enabling this sort of empathy-infused IT rounding is what's called the journey mapping approach, where the focus is really on interactions, not on a transaction, not on a ticket. It's multiple interactions over an experience that a person has had with IT. Now let me show you an example of this so you understand what I'm saying. Here's an example of Sharon, who's a nurse, and this is her journey map. This is how a journey map looks like. So just look at the top line, which is in green. That's called the experience story. And so here's how it works. So when the mapping begins, you create what you call a persona, a user profile. So you get to understand the person that you're solving for. In this case, Sharon is a 45-year-old nurse, 20 years of nursing experience, married, has 2 children. She embraces technology in the hospital, seen as the go-to person by nurses and her fellow clinicians and doctors. She enjoys interacting with patient families. She takes pride in providing high-quality care. So now you know a little bit about who we are solving for, and then Sharon was asked for a story, right? Because empathy interviewing is about evoking stories. And so this is a true story, and this is from Citrix, by the way. And so in this story, Sharon begins by entering the data into the EMR. Fine, that's normal, right? She's entering data, and then she experiences a power surge. The PCs go black. All the respiratory monitors, the alarms go off on the floor with her patients, okay? Then she has to use respiratory bags to stabilize the patients. Now she hears the power is back up, thank God, but she has to manually start the computer, restart the computer, and that takes about 20 minutes. So you're picturing this, right? She's putting the respiratory bags, and now she's waiting for the PC to come back up. And she logs into the EMR at the nurse's station after she's done that, after it's back up, and spends 30 minutes resubmitting all the data that she just entered. Wow. But then she finds out, then she goes to the patient room to pass out the meds, important part of the job. She enjoys doing it, enjoys interactions. So she's gone to pass out the meds, and she tries to log into the EMR in the room, and she finds out that she's locked out. So she goes back to the nurse's station, unlocks, logs out, and then comes back to the patient room and signs in. She calls IT about these login issues. She waits on hold for 20 minutes, and finally she gets the issue resolved. Right? So this is the story that we've collected from, that Citrix collected from Sharon. Now, stay with me here. So we've seen the journey line on the top, but the journey mapping process itself tries to also understand what's going on around Sharon. So who are the other people that she's interacting with? What are the other systems that she's interacting with directly? And so this is on stage. But you also try to understand what's going on backstage. Who are the people and what are the systems that she's not directly coming into contact with but can influence her experience? And so now you've collected the on stage, the backstage, you've created a journey line, you're going back, and now you're saying, on the top line, you see that attitude, that line is blank. You can take this and fill it up if you want to do the exercise. But you're saying, what are the attitudes of Sharon as she went through this journey? Well, what was she feeling? Not good or bad, but her inner monologue. What was she thinking to herself? Maybe she's thinking, oh my God, I'm supposed to be with the patient, but here I am at the computer, I'm not feeling productive. So you sort of map out all the attitudes at each stage of that journey, and some of this is, surfaced during the interview. She might say it, and some of this is putting yourself in the person's position and thinking what's going on. So you're empathizing. And so you fill up that line of attitudes, and now you say, in all of these attitudes, which of these are positive? Mark them with green. Which of them are negative? Mark them with red. So now you know, visually, over a period of an experience, what are the highs and lows of a user as they go through that experience. Now, we're not trying to solve this problem just for Sharon, right? As IT, we're trying to solve this problem for all of our users. We've made a business commitment to our users, saying, we're going to provide a good experience. So you're looking at those business objectives, whatever your objectives are. Let's say reduce calls by 15% to the help desk. So you're looking at that business objective, you're looking at these highs and lows, and you're saying, where in this journey am I at a risk of not meeting these objectives? And what is the critical point where I can make a change that can actually improve the experience? And you pick that critical point, and then you brainstorm ideas. And then you say, here's an idea, here's the attitude that's going to change, and here's the business objective that we're going to realize by doing that. So what did you do now? And in doing this, you sort of surface more than one problem. The problem is probably not the login issues, and maybe that is a problem, but there's other problems too. So you can surface more than one problem. And you make it collaborative when you're brainstorming these ideas. You can include Sharon, you can include any other business partners who have a role to play in coming up with the solution. So you're really busting silos here. So you've spoken to your end user, you've surfaced an experience, you figured out what really hurts your business objectives, you picked a moment that you can really fix, and now you're brainstorming solutions and ideas, right? And so this sort of approach, again, surfaces a number of different things. You're solving problems, but you're also looking at efficiencies. Now, let's move to the next step. How do we, and so these are the 4 steps. You talk to your end users, you understand the role of empathy, you try to design experiences that matter, and then you measure how people think and how they feel about the services. So how do you measure how people think and feel about their services? What's your approach here? Is this the approach? Because these metrics are perhaps important, and they provide certainly some benchmarks that you can use. And we've used one of these in the previous example, haven't we? But here's what I'd suggest. Look at these metrics and do two things. One, ask yourself what each of these metrics really means and what your customers make of it, as you've seen on this slide. And number two, think, are you using these metrics as an end goal, or are you using this metric as a launchpad for an improvement, for something else? And again, like I said, I think these are useful and they give you a pulse of how you're doing in terms of your performance, but this is not measuring satisfaction. But here's something that does measure satisfaction. How many of you use Net Promoter Scores? Okay, I see a few hands. Really simple concept, and it's really based on asking the question, how likely are you to recommend on a scale of 0 to 10? How likely are you to recommend this service or this product on a scale of 0 to 10 to somebody else? That's it. 0 to 6 are your detractors, people that don't like your service. 9 and 10 are promoters, people that love your service. 7 and 8 are impartials. So NPS is just percentage promoters minus percentage detractors. The higher your promoters, the great it is, because that's measuring satisfaction. That's really measuring people that would advocate for you. And you can word the question differently here, just like we've done here. It's not how you word the question as long as you're asking about experience, but it's more so about what you do with the data that's coming back. Are you calling these detractors back and saying, hey, how can we improve your experience? Are you sort of trying to surface trends to improve your performance? Are you benchmarking yourself against somebody else? That's what's more important. Now, if you want to experiment, if you want to take a step beyond NPS, could you measure time to smile? Could you? Time to smile is the total time elapsed between when the customer has had their ability to use the product or service interrupted to the time when they're back to a happy state. Right? Certainly seems meaningful, right? So not time to respond, not time to escalate, not time to mitigate, not time to relieve, time to smile. Can you do that? Now, Todd Dunn from Intermountain, he talks about the concept of love metric. Love metric is measuring, can your product or service deliver what the users would love it to do. So love metric is measuring what is being expected as a benefit by the customer, not what you're actually delivering, not if you're on time, not if you're on budget, not if you're on scope, because those are things you're paid to do. Can you deliver something that people would love to use? Can you find practical ways to implement measures like these in your work? After all, empathy and experimentation are two most fundamental principles of design thinking. Now let's pause here with the techniques. We often hear now, lately we're hearing about design thinking being used in the concept of patient-centered care, and that's great, that's refreshing, we have to do more of that. But we rarely hear about it in context of clinicians. I'm so glad that UPMC is doing this. But to make patient-centered design work, you have to fix doctor-centered design. We should be designing tools and services for clinicians with empathy and with compassion, because they deserve to be understood no less than the patients. Now, I leave this here. We're going to talk about some case studies. I'm going to turn it over to Rasu. We've collected some interesting approaches and technologies. I will say that we've included a lot of data on these case study slides because we want you to have them for reference, but stay with our narrative and we'll pull out the right points for you to look at.
I think I can just speak from here. If you move to the next slide, because I just have this one thing that I wanted to talk about. So at UPMC Enterprises, I mentioned earlier, lots of whiteboards, lots of sticky notes, and this is exactly how it looks like. So this, in particular, is one project that we've been working on. And there are multiple projects that we're working on across the board. What's really interesting about our approach in embracing the concepts of design thinking and human-centered design is that across the 4 key domains that we have at UPMC Enterprises, so clinical tools, population health, business services and infrastructure, and consumer. So these are 4 key domains of pain points that exist across healthcare, where we're dedicating time and money and resources to work hand in hand with our clinicians, with our operational folks, with patients across the board, and creating really insightful solutions that hopefully will transform where healthcare needs to be going to, right? So moving from where healthcare is to where it needs to be. In this particular case that you see up on the screen, we've been doing the journey mapping that Santosh talked about, the NPS scores. What we actually have, this in particular, is an imaging project where we're looking at the solution that currently exists. So multiple silos of information systems and RIS, the radiology information system, PACS, the picture archiving communication systems, 3D imaging, and voice recognition, which is how we use the tools to dictate and document. And we're trying to have less of an application-centric view and more of a patient-centric view. So how do we bring the context of the patient to fruition? So we've engaged patients, but we've importantly also engaged clinicians, radiologists, and others. What's really interesting is in this innovation shop, we have clinicians that rotate through our innovation center, right? So Bakery Square at UPMC Enterprises, we have radiologists that are coming in and actually performing their reads, and sitting down hand in hand with our design thinkers and analysts and data scientists. And we're going through these exercises that you see on the screen. So we're really making a lot of progress as a result of the specifics of how we're doing it. So I like to say that ease of use may be invisible, but its absence sure isn't. Santosh.
Thanks, Rasu. So I'm going to show a few different case studies now. So this first one is from Docent Health. And it's an interesting approach. And this is also a little bit experience-based. And they're saying, can we mirror the data-driven revolution in clinical pathways and clinical decision support, which is assisting care teams with decision-making, giving them confidence about delivering the right care? Can we mirror that data-driven approach to help the care team also better understand, measure, and manage the patient experience component of care? Can we provide the data and the confidence for doing the right thing for patient experience? And in doing so, help them better deliver patient care, but also connect them to the human side of patient care by enabling them with the right contextual information about the patient. Because so often we hear that clinicians miss the human element of healthcare that impassioned them in the first place. And so Docent Health has a technology platform that supports this mission by collecting the data, but they also complement this platform with a staffing model. They have these docents that they deploy, and these are specially trained staff that serve as patient liaisons in conjunction with the direct care providers. And they interact with them throughout the course of the journey and capture needs and preferences and motivations, as well as surface relevant insights to the care team during the rounds and during the huddles. Now, here's another one. How many of you are familiar with Augmedix? Okay, I see a few hands. Augmedix offers a Google Glass-powered remote scribing service that improves patient productivity and interaction with patients. Now, you see the Google Glass on the left, and on the right, what you see is the point of view of the doctor. And the physician wears the glass during the exam that streams audio and video to a remote scribe up in the sky. The trained scribe creates notes in real time and provides relevant info to the physician when asked. And physician can communicate verbally with the scribe, and the scribe will communicate back via text and via what you see on the heads-up display there. And then at the end of the visit, the note is presented to the physician. They review it and they approve it, and the offering is HIPAA compliant. Patient is asked for consent up front, and you see that the patient consent is about, on average, 98%. And this approach frees the doctor from about 2 hours of documentation every day on average, and allows them to see about 25% patients every week, more patients every week. And so they have about 500 providers. The numbers increased since we made the slide using this, and they plan to scale it over to 1,000 this year and to 10,000 in 5 years. And you see the kinds of people that have invested: Dignity, Sutter, TriHealth, Catholic Health Initiatives, and here's why: because of some remarkable results. And what I've not included here are the patient Gini scores. Patients feel doctors are able to better listen, build rapport, and they feel doctors spend more time with them. Interesting approach, isn't it? Physicians feel that they're more productive, and patients feel that the doctors have spent enough time. Now, yes, there's probably other considerations that you're curious about, but from an experience point of view, from a UX point of view, from a UI point of view, this is a new technique. Now here's more conventional looking approach, a documentation tool, but one that's co-designed with physicians to be smart, elegant, powerful. Great example of how intuitive UI can contribute to a delightful user experience. I won't go into the details of this, but I think they're on the exhibit floor. Not promoting, no conflict of interest. Go check them out if you have the time at some point. Now I'd like to shift tracks here a little bit and focus on customer experience, which is also a key component of UX. And what I want to showcase on this slide and the next couple of slides, we just have a couple of minutes, is some remarkable efforts from provider organizations to transform into consumer-centric organizations. New York Presbyterian on this slide, folks, for UX for NYP is an innovation imperative. And the aspects that I want to call out are the ones that we discussed, employing empathy, focusing on the experience, not on tickets, getting staff trained in Ritz-Carlton style philosophy, and the staff actually, they go out and round on clinicians, and at the end of the round, they provide a letter which says, here's your shopping cart of issues, and here are the fulfillment dates for these issues. How powerful is that? Now, the next slide is, here's Stanford Healthcare, very clearly articulating their IT imperative, which is building loyalty through premium experiences. Another unique approach to IT rounding, and what I want to show you here is the rounding card. Every employee is encouraged to perform regular rounds. They all have these cards, which provide them an additional touch point to personalize the interaction, and they have space to actually write down what their promise is at the end of the round. And so that's another interesting approach. Beyond this, they've also created a workflow that sort of helps people keep a track of the issues that came up during rounding, and how to sort of communicate with the customer, and how to communicate internally within the teams. So sort of projecting one phase of IT. Now this last case study here is a little bit different, whereas New York Presbyterian and Stanford were more innovation and consumeristic focus to it. This one is more operational focus. So in addition to ongoing improvement efforts, once a quarter, IT partners with nurses, and they go out on this operational blitz to hunt for problems and fix them. And the results, the strongest and most quantified that I've seen in terms of the approach's impact on care team experience, but also on internal IT employee engagement. Now, like I said, all these slides are available to you. In summarizing this section, and before we get to Q&A, let me say that IT is perhaps the only segment that touches the entire healthcare continuum. Now, our hands may not touch the patients, but we do touch their lives in ways unseen. And in using our hands every day for our work, it doesn't matter what we do. In using our hands to pull network cables, to answer service desk calls, to create order sets, to develop strategies, to manage projects, to create apps, we are using these hands to help our clinicians care for our patients. We are helping care for our patients. And that's meaningful. Now, before technology exploded, doctors used to carry these toolboxes around. Today, we are that toolbox. Our work are those tools, right? So it's meaningful, and there's no doubt about it, but there's much opportunity here to make it more thoughtful, more empathetic, and more delightful to people for people to appreciate our work. So I'll leave it at that, and then we'll get to Q&A.
Should we just get to Q&A then?
It's just one more.
We'll cut to Q&A maybe.
Okay.
Yeah. These slides are available, folks, but we want to give you a chance to ask questions and engage in some dialogue as well.
Yeah, one of the most important parts of this session is for you to take in this information and then ask the questions for what touched you, what resonated with you. I know for me, when I was working at Yale New Haven, we did the IT nurse rounds, and that was a big deal. It made a huge difference. So let's hear from you. There's spikes in the middle of the room. Thank you.
No, I don't
Hi. So, in one example, you talked about this nurse Sharon's journey through the IT experience, and you had suggested that you workshop that example to, optimize your decisions. So, I'm a statistician, which is, I guess, good or bad depending on who you ask. But for us, we always want to look at, what's the trend, and then kind of respond to that. So, kind of how do you weigh that one experience, and how do you decide that's the one experience you want to look at versus a large enough sample size to make that decision and kind of workshop that?
Yeah, that's a great question, but I've shown one example. You're not just going after one experience. You can find as many as you want during your rounds and bring them out and geek out, on how to sort of improve that experience. So it doesn't have to be one most ideal, biggest problem that you pick. You can bring back as many and take that approach to see how to improve the overall experience during that interaction.
To me, one of the most powerful slides that you had was the one that showed the IT metrics versus what the clinicians feel when they see that. So IT can feel like they're doing a great job because the response time is excellent and their coverage is great. But when you're the clinician, you're trying to take care of that patient and you can't get a human on the phone, your satisfaction isn't going to be there, even if the stats show that things are good.
And it is an iterative process, right? So the Net Promoter Score, the NPS, you can continue to increase the N in terms of the number of times that you do this, but also the number of clinicians and others that you talk to as well. So statistically, you can really go crazy with all of the data.
With NPS, yes.
Yep.
Go ahead.
Mehul Sheth, Adventist Health Systems West. My question was, with the new requirements for UI, UX and the EMR vendors, the human-centered design, do you think that significantly made a difference? And if not, what would they need to do to go further with that to bring that really into the design of the EMR, as you said, before it's even, code is written?
I think it is starting to make a difference, even in the solutions that we have. So, at UPMC, we have both Epic and Cerner as our primary EMRs. Epic in our ambulatory care settings, and Cerner primarily in our inpatient settings. You can see in the newer updates that we have of the solutions, the UI is better than what we've had before. And it's not just the UI; it's also the user experience, right? And they've been thinking through this. They've been working with our physicians, our clinicians, nurses, and from many other institutions as well. I think the challenge that exists, not just for us, but for the incumbents, the electronic medical record system companies, and others that are designing apps and solutions, is there are needs that we currently have in this environment that is primarily volume driven. There are specific needs that we have around documentation and regulations, and those needs need to be met, right? So it's this race of, yes, we're moving to value-based from volume-based, but the reality is that we're not quite there yet, right? So even for a payer-provider organization like ours at UPMC, we have many successful value-based metrics that we're actually tracking, specific projects around patient-centered medical homes and shared risk and shared savings. But in large parts, when you talk about the industry as a whole, there are specific things that still need to happen around documentation and billing and everything else. So that's, again, where the power of technology comes in. As newer technological capabilities like artificial intelligence and machine learning, for example, come in, scribes, as Santosh described earlier, chatbot technologies, right? Where this is going, I think, is really exciting.
I think it helped start the conversation. So people were talking about the user experience and testing for that before they really understood what that was. But I think one of the big things that's missing is the user experience in interoperable or non-interoperable systems. Mm-hmm. So maybe you can talk a little bit about that, Santosh. What happens when you've got 4 or 5 different systems that are very usable, but they're not usable together?
I think that's a great question, and the most immediate example that comes to mind is patient portals. You could have 6 instances of the portal from the same vendor. Forget about different vendors. And so, it is challenging, And I think there's a number of workarounds that people are trying to use. Using a common landing page, trying to take a few different technical approaches to integrate things at a more data layer. But I am actually very hopeful, and I'm excited about the API-driven innovation that's launched in our industry. And I think once that takes off, and once the patient has the power to collect data from wherever and manage it the way they want, I think that's going to change the game. And on the clinician side, yes, that's again a challenge. I mean, you're already toggling between 6 different applications, and then you add on another, care coordination platform to the mix, and there you go. You're forcing them to open yet another application that is outside of the workflow.
Yeah, we have 4 secure messaging apps, so
yeah.
Thank you.
There you go. Yeah.
Thanks.
Go ahead in the front.
Hi, I'm Dave Ackerson, and I'm with the Seattle Cancer Care Alliance. We're part of the Fred Hutch, UW Medicine, and Seattle Children's. And Razu, I'm interested in your innovation center. I have some of the ingredients, and I've been thinking about how to expand what we're doing. We have a digital health team. We've got a lean team. We have physician leaders that are interested in behavioral experience and user experience. How did you take the steps to develop UPMC's Innovation Center?
Yeah, so that's a great question, and it actually speaks to the entire content of what we discussed today. We've been doing this for a while at UPMC in identifying, putting our finger on the pulse with regards to what these pain points might be. And innovation, I think it's one of the things, lessons learned, right? Because we've been doing this for a while. One of the things I'll tell you right up front, even as you're embarking on this journey, is don't think about innovation as this thing that happens in this group, in this building, right? Innovation, it should be second nature to everything that goes on across the organization, on the operational side, the clinical side, the quality folks, right? What we're doing is we're creating more of an enablement set of capabilities, leveraging principles of design thinking and human-centered design, but also at UPMC Enterprises, we're putting our money where our mouth is. So this is taking it perhaps a step beyond and realizing the fact that it's great to have methodologies like human-centered design and design thinking and an innovation center, but to make sustainable innovation happen, we also need to look at creating solutions that can really transform the way that care is transformed. So that's by entrepreneurial success, and that's what we do at UPMC Enterprises. So we invest in companies, we have startups, we have, but the key differentiator in all of this is that all of the things that we talked about earlier are the essence of what we're doing, whether it's in specific product features or whether it's in deploying solutions or whether it's in these startups that we're birthing all the time.
So is your center then a sort of a place or a space where clinicians can then come and
Yes, absolutely. So we're engaging with clinicians day in and day out. Before we decide to invest in any one opportunity or before we decide to actually go down the path of even looking at a certain pain point, we engage our clinicians and we engage those end users.
So these guys will be up here for you to ask some individual questions. We're coming to the end of our time, but what I would say is there's nothing that kills innovation more than saying, you must have 3 innovations this quarter, right? So it's one of those things that putting metrics on, that intuition doesn't work, but for those of us that work with an administration many times that are very metric driven, that's what happens. So I think being able to open it up so that clinicians and IT folks don't have that pressure, that's when the ideas will come. All right, thank you.
And what I'd request is, open your mobile apps and please do provide evaluations. I wish I could ask you for an NPS score and we could ask you rate it and ask you how likely are you to recommend this to another colleague. But for now, there's evaluation forms available on the mobile app. So please navigate to the session and provide your feedback.
We wanted to get to the Q&A session, so we cut the last part short, but the presentation is available online. The next slide to this actually talks about it's essentially a condensation of all of the things that we've talked about, so some specific take-home nuggets. So if you get the chance, download the presentation and do have a look at it.
And share your ideas. Thank you.
Thank you very much.